This is the second lecture from the ECG series, and we'll be reading about the waves. So before going into the individual waves, let's just have an idea. So this is the pictorial image of the heart. So SA node will be present here. So here there will be SA node. Here there is AV node. Then the bundle of is, then the right bundle, then the left bundle. Then there will be Purkinje fibers throughout the ventricle. Okay. So action potential will start from the SA node. It will go through the internodal fibers to the AV node, and then through the bundle axis it will go to the right and left bundles, and then through the Purkinje fiber it will stimulate the ventricle. Okay, so the SA node is the pacemaker from which the action potential will start. So it will first stimulate the atrium. So the atria will be the first one to depolarize, and it is the right atrium because SA node is present in the right atrium. So right atrium will be depolarized first, followed by the left atrium, and this atrial depolarization together will be shown by the P wave. Be shown by the P wave. Okay. Now now the action potential will reach the AV node, and in AV node there will be a delay in the conduction of the action potential. That's why there will be isoelectric line from P to QRS. Okay. So the P wave is atrial depolarization, then the isoelectric line which is representing the AV nodal conduction delay. Then the action potential will go through this bundle of his, then the right bundle and left bundle. Among these two bundles, the left bundle will be the first to be activated. Left bundle will be the first to be activated. Okay. So once the left bundle is activated, the direction of the action potential will be towards this. So the septum will be first one to be depolarized in the ventricle. Septum is the first one to be depolarized. So the septal depolarization direction will be from left to right because the left bundle is activated first. Okay. So this is shown as a small negative deflection in lead 2, that is the Q wave. Okay. That is the Q wave. Then the entire ventricle will be depolarized through the Purkinje fibers, and the entire ventricle, the net direction will be towards this like this. Because the left ventricle will have a larger mass, it is more thick, it will pull the vector towards it. So the net ventricular vector direction will be downwards like this. Okay. So in the lead 2, which is in this plus 60 direction, it will have a positive wave that is known as the R wave, positive wave that is known as the R wave. And in the end, this portion of the ventricles, this upper base of the ventricle will be depolarized, and this ventricular depolarization direction will be like this, which is opposite of the lead 2. So they will produce again a negative wave, that is the S wave. After that, again there will be uh, isoelectric segment, which represents the depolarization, which represent the gap between the ventricular depolarization and the repolarization. And finally, there will be ventricular repolarization, which is shown by the T wave. Okay, ventricular repolarization, which is shown by the T wave. The ventricular repolarization happens from epicardium to the endocardium, from the epicardium to the endocardium, and it will be shown as a T wave. It will be shown as T wave. Okay, so these are the basic waves, the P, QRS, and T, which you must be knowing. And remember, this structure of the ECG is valid only for lead 2, not for all the leads. Okay? Because lead 2 is present, lead 2 represent the same axis as the normal cardiac axis, that is plus 60. That's why for convenience, we always depict this, the usual ECG, whatever is seen in the lead 2. And lead 2 is also the best lead to see the rhythm disturbances or the arrhythmias because it is in line with the cardiac axis. Okay. So from this you can understand that these waves will be different in different leads depending on the axis of the individual leads. Okay, depending on the axis of the individual leads. Anyway, first let us start with the P wave. That is the atrial depolarization. Now, what are the basics you should know about the P wave? P wave, remember P wave is upright. P wave is upright in lead 2 and it is biphasic. It is biphasic in lead V1. It is biphasic in lead V1. Okay. Next thing is duration. I'll be telling you why it is biphasic in lead V1 and why it is upright in lead 2. Lead 2 I already told, and this will be uh, upright because the P wave is atrial depolarization. Atrial depolarization happens like this in right atrium. The depolarization will be like this. In the left atrium, the depolarization will be like this. So it is in line with the lead 2. It is in, so lead 2 is like this in the axis of the heart. So it is in line with the lead 2. So that's why you will get positive waves or upright waves for both right atrium and left atrium depolarization. That's why you get a single P wave in the positive direction. For V1, V1 will be present here, somewhere here. So right atrium direction will be like this, that is towards the axis of the V1. So V1 axis will be somewhere like this. So right atrium depolarization, it is towards the V1, so that will produce a positive wave. But the left axis depolarization, that is this one, this is somewhat opposite to V1, so this will be producing a negative wave. So in the V1, the P will be biphasic. The first part represents the right atrium depolarization. The second part represents the left atrial depolarization. Lead 2 it is upright, of course, and the first part will be is representing the right atrium, and the second part is representing the left atrium. Okay. So this is about morphology. Next about the duration. Duration will be less than 120 milliseconds. Less than 120 milliseconds. Less than equal to 120 milliseconds. I already told you. One small box is 40 milliseconds or 0.04 seconds. So P wave duration will be less than equal to 3 small boxes. Okay, less than equal to 3 small boxes. Now about the amplitude. Remember in lead 2, the amplitude will be 2.5 mm. Maximum amplitude will be 2.5 mm. In lead V1, the amplitude will be 1.5 mm. 1.5 mm. Okay. So this is about the amplitude and the duration. Okay, so these are the basic things, the normal findings of the P wave that you need to remember to understand the pathologies involving the P wave. I will see P waves in various abnormalities. So as I told you, so in lead 2, P wave will be positive. Lead 2, P wave will be positive. The initial portion, the first portion will be representing right atrium. Second portion is due to left atrium. Okay. Now what happens whenever there is a right atrial enlargement? Whenever there is a right atrial enlargement. Whenever there is a right atrial enlargement, the first portion will go like this. The right atrium portion will be going like this, and followed by the left atrium. So only the amplitude will increase. Only the amplitude will increase. Only the amplitude will increase. So what happens whenever there is a left atrial enlargement? Whenever there is a left atrial enlargement, the initial part is not affected. But the second part, there will be a increase in the amplitude. And the duration because of the left atrial enlargement. So in left atrial enlargement, you will get a bifield. PF. In right atrial enlargement, you will get a tall PF. Okay, as you can see in this image. Okay. Now, in the you must be thinking that why there is no notch in the right atrial enlargement, because in left atrial enlargement we are having two different depolarization for right atrium and left atrium, so we are getting a notch in between, but we are not getting a notch in the right atrial enlargement because the action potential starts in the right atrium. So majority of the part of the P wave will be covered inside that right atrial depolarization. Okay, majority of the part of the P wave will be covered inside the right atrial depolarization, and that will be the predominant one. So only the amplitude will increase. But in case of left atrial enlargement, because the action potential starts from the right atrium, first depolarization of the right atrium will be prominent, and it will be followed by a prominent left atrial depolarization. Okay, so everything because everything is happening here because the action potential is starting from the right atrium. Okay, because it is starting from the right atrium. Whenever there is a right atrial enlargement, the initial depolarization will be prominent in the initial depolarization will be prominent. So there will be a tall wave, and the left atrial depolarization will be masked inside that. But whenever there is a left atrial enlargement, the right atrial depolarization part will be there, followed by a significant left atrial depolarization. That's why there will be a bifid P wave. So you'll get a tall P wave in case of right atrial enlargement, and you'll get a bifid P wave in case of left atrial enlargement. Many times this tall P wave in case of right atrial enlargement is called as P pulmonale, and bifid P wave in case of left atrial enlargement is known as P mitral. Of course, if there is a mitral valve stenosis, you will get a significant left atrial enlargement causing this kind of picture. So the name is derived from that P mitral. Similarly, in case of, for example, uh, pulmonary hypertension or pulmonary stenosis, we'll get a right-sided predominance, right atrial enlargement that will cause a tall P wave that is known as P pulmonale. Okay, so this is about the morphology. But if you go to the numbers, I told the normal amplitude in lead 2 is 2.5 mm. Normal amplitude will be 2.5 mm. Okay, and here in case of right atrial enlargement, the amplitude will be more than 2.5 mm. In case of left atrial enlargement, the amplitude is not increasing. It is the duration that is increasing. I told the normal duration is less than 120 milliseconds or less than 3 small boxes. So here the duration will increase. The duration will be more than 120 milliseconds. More than 120 milliseconds or more than 3 small boxes. Okay, so this is what will happen in the lead 2 in case of right atrial and left atrial enlargement. Now we'll see what will happen in the lead V1. Remember to look at the P wave, to interpret the P wave, you have to look at only two leads, lead 2 and lead V1. These are the two most important leads to look for the P wave morphology changes. I will go to the lead V1 and what will happen in lead V1. As I have already told you, V1 will have a biphasic. So you can see here this is the normal P wave in lead V1. This will be biphasic. The initial part, this is due to right atrium and this is due to the left atrium. Okay. So whenever there is a right atrial enlargement, what will happen whenever there is a right atrial enlargement? This initial portion will again increase. So as you can see here, this one, you can see this here, this is a P wave, and you can see the right atrial portion is increased. So this is right atrial enlargement. If you go to the numbers, I told the normal amplitude here is 1.5 mm, 1.5 mm. So here the initial portion amplitude will be more than 1.5 mm if there is a right atrial enlargement. Okay, if there is a right atrial enlargement. If there is a left atrial enlargement, the second part will be affected. The negative part will be affected, as you can see here, this one. So here again, it will be more than 1 mm deep, or more than 40 milliseconds, if you go to the numbers. Okay, these are the numbers you have to remember for left atrial enlargement, and this is the number you have to remember for right atrial enlargement. For right atrial enlargement, the positive amplitude will be more than 1.5 mm. For left atrial enlargement, the second part will be more than 1 mm deep, and it will be more than 40 millisecond wide. Okay, so the prominent negative part due to left atrial enlargement. Okay, so these are the changes that we'll find in lead 2 and lead V1 in case of right atrial and left atrial enlargement. Now this is the summary. Lead 2, I told you will get a upright positive P wave. In lead V1, you will get a biphasic P wave. In right atrial enlargement, I told the initial part will be affected. The first part will be affected, so we'll get something like this. But in most of the ECGs, we'll get a tall P wave, that is P pulmonale, I told. In V1, you will get a prominent first part. The numbers, if you remember, this will be more than 1.5 mm. This is more than 2.5 mm. For left atrial enlargement, I told the second part will be affected and it will cause a bifid P wave. Here the duration will be more than 120, more than 1 seconds, more than 120 milliseconds. And in the lead V1, the second part will be affected. Here it will be more than 1 millimeter deep, more than 1 millimeter deep, and more than 40 millisecond wide, more than 40 millisecond wide. If there is both right atrium and left atrial enlargement, you will get a combined picture. You will get a combined picture of both. Okay. Now, what are the other abnormalities? We have discussed about the P mitral, that is the bifid PVF due to left atrial enlargement. We have discussed about the P pulmonary, that is the tall PVF due to right atrial enlargement. Now, what are the other things? So, in which condition we get PVF inversion and which condition we get a variable P wave morphology. Okay. In this, we have already discussed about the mitral. We have already discussed about the P pulmonary. Now, what is P wave inversion? In which condition we get a P wave inversion? This is very simple to understand. P wave inversion we will get in any ectopic atrial rhythm, atrial rhythm, or junctional rhythm, or junctional rhythm. What do you mean by that? Again, the same image. Usually, the action potential starts from the SA node here, goes to the AP node. But if the action potential starts from here, due to any cause, action potential is starting from here. So the net vector direction for atrial depolation will be like this, in the opposite direction of the normal vectors. Opposite direction of the normal vector. So we will get a negative PF, we will get a negative PF or PF inversion. Similarly, if the action potential is starting from the junction, that is the AV node junction, also the atrial depolarization will be like this in the opposite direction. So we will get a negative P or P wave inversion. So in these two conditions, ectopic atrial and junctional rhythm, you will get a P wave inversion. Okay. Now, what is the difference between them and how to differentiate ectopic atrial and junctional rhythm if we are getting a negative or inverted P wave? You see here, you can see here, this is the P wave. Sorry, this is the Q wave. Here you can see this is the P wave, and you can see this is a bifid P wave. Bifid P wave. So this is example of P mitral. Actually, this is example of P mitral. In the second image, you can see this is the P wave. You can see very tall pointed P wave. So this is P pulmonary. That is right atrial enlargement. So this is right atrial enlargement. This is left atrial enlargement. If you see here this is the P wave. This is the P wave. This is the P wave, and this is the P wave. In the second image, you can see this is the P wave. This is the P wave. This is the P wave. So here you can see the P wave is inverted. So this is inverted P. But I told you inverted P can be seen in two conditions. One is ectopic atrial rhythm, another one is junctional rhythm. Okay. So how to differentiate them? You have to see the PR interval. PR interval is starting from the P. PR, we have to see what? PR interval, PR interval. PR interval is start of the P and start of the QRS. So this is the PR interval. The PR interval. So if the PR interval is less than 120, it is junctional rhythm. So this is junctional rhythm. The PR interval is more than 120 milliseconds. 120 milliseconds is ectopic atrial rhythm. Okay. So whenever there is an inverted P wave, you look at the PR interval. If it is less than 120 milliseconds, it is junctional rhythm. If it is more than 120 milliseconds, it is ectopic atrial rhythm. Now, why this is happening? This is happening. You see here, if the action potential is starting from this ectopic atrial region, still it has to cross the AV node to go into the ventricles. Still it has to cross the AV node to go into the ventricle. That means the AV nodal delay. The AV nodal delay is present in case of ectopic atrial rhythm. In case of ectopic atrial rhythm. But this AV nodal delay is absent if it is a junctional rhythm, because junctional rhythm AV node itself is causing production of the action potential. So it will give action potential to both atrium and the ventricle in almost the same time. It will give action potential to both atrium and ventricle almost the same time, so there won't be any heavy nodal delay. Okay, so there won't be any heavy nodal delay. So in junctional rhythm, heavy nodal delay is absent, but here heavy nodal delay is present. Heavy nodal delay is present. So that's why the PR interval will be more in case of ectopic atrial rhythm, and the number is 120 milliseconds. If it is more than 120, it is ectopic atrial rhythm. If it is less than 120, it is junctional rhythm. Okay. Now the last part of the P wave abnormality is the variable P wave morphology. It's very simple to understand. If inside the atrium there are various trigger points producing multiple action potential at various time point. So these are all the trigger points. The first action potential is produced by this. The second action potential is produced by this. The third action potential is produced by this, and so on. So if there are multiple trigger points which are producing action potential inside the atrium, so they will produce variable P wave morphology depending on the location of those trigger points. Okay. If you see this ECG, you can see this is one P wave here. Then this is one P wave. Then this is one P wave. Okay. So you can see the P wave morphology is different in all the complexes. And here in the second ECG also you can see this is a P wave, this is a P wave, this is a P wave, inverted P, this is also inverted P. Again, this is upright P, this is a tall P. So again, various P wave morphologies. Okay. So this is multifocal. This multifocal atrial rhythm. Multifocal atrial rhythm. Now, as per definition, if there are more than equal to three different P morphology, that is known as multifocal atrial rhythm. That is known as multifocal atrial rhythm. And if the rate is more than 100 beats per minute, that will qualify as multifocal atrial tachycardia, MAT, multifocal atrial tachycardia. Anyway, more on this we'll be studying in the arrhythmia section. For as of now, just remember if there are more than three different PVF morphology, that is known as multifocal atrial rhythm, and the rate is more than 100, that is multifocal atrial tachycardia. Okay. Now that's all about the P wave. Now coming to the Q wave, the next wave in the ECG, the Q wave. Okay. So the Q wave, first of all, we'll start with some of the basics. But before going to that, let me just tell you that what do you understand by Q wave? What do you understand by the Q wave? So if this is the QRS complex, we know this is the Q, this is R, this is S. Now there is always a confusion here in understanding that we all initially believe that Q wave is the first wave in the QRS complex, but that is wrong. Okay, so Q wave is the first wave of the QRS complex. This notion is wrong. But what you need to understand is Q wave is the first negative wave in the QRS complex. Okay, it is the negative wave that precedes R wave is the Q wave. Okay, and the negative wave that follows R wave is the S wave, and the first positive wave in the QRS complex is R wave. Okay, I hope it is clear. In the QRS complex, the negative wave that precedes R wave is the Q wave. Okay, the first positive wave is R wave, and the negative wave that follows the R wave is S wave. Okay, I hope this is clear now. Okay, so sometimes in some leads you will find something like this. So in this, uh, in, in this you can see there is no Q wave because the first wave is positive wave, so this is R wave, and the second wave is negative wave which is following the R wave, so this is S wave. So this QRS complex is known as RS complex. This RS complex, there is no Q wave here. Similarly, we see this. You see this. The first negative wave is of course Q. Q is followed by the positive wave, that is R wave, but there is no S wave here. There is no S wave, so this is known as QR complex. Okay, so I hope it is clear. So the first negative wave that precedes R wave is known as the Q wave. So usually Q wave is a small wave. But Q wave is prominent in lead 3 and lead AVR. Apart from lead 3 and AVR, the Q waves are not prominent. Prominent means it is deep in lead 3 and AVR. So in any other lead, if you are getting a deep Q wave, that means it is pathological. Okay? That means it is pathological. Similarly, Q waves are not seen in V1 to V3. Right-sided leads will not show the Q waves. Let me just tell you why this is happening. I have already told that the depolarization that is happening, in the septum is happening from the left to right because left bundle is getting the impulse first from the AV node. So left bundle is depolarizing first, so it will depolarize the septum from left to right, right. That's why this septal depolarization will produce a small negative wave in the lead 2. In the lead 2, I told this is in the direction of the heart, in the direction of the cardiac axis. So so the septal depolarization is opposite to the uh, normal direction of the lead 2. So it will produce a small negative wave, and that is the Q wave. Small negative wave, that is the Q wave. But this septal depolarization will not produce any negative wave in lead V1, V2, and V3 because you can see here V1, V2, V3 are in this direction. So the septal depolarization direction are in the same direction of V1, V2, V3. So usually in V1, V2, V3, you will not find a Q wave. You will not find a negative wave before the R wave. So Q waves are not found in the V1 to V3. So if you are getting negative waves in V1 to V3, sorry, if you are getting Q wave in V1 to V3, that means it is pathological. Okay. So Q waves in different leads, I told you that Q waves are only prominent in lead 3 and AVR, and they are absent in V1 to V3. V1 to V3, they are absent. Okay. So loss of normal Q waves. Remember this point: if normal Q waves are absent in V5 and V6, if they are absent in V5 and V6, that means there is left bundle branch block. Left bundle branch block. Now, why this is happening? If you see again this image, if there is a left bundle branch block, if there is a block here, that means the action potential is not coming to this. That means the right bundle is getting activated first. The right bundle is getting activated first. If the right bundle is getting activated first, the septal depolarization will be from right to left. It will be from right to left. If it is from right to left, it will be in the direction of lead V5, V6. It will be in the direction of lead V5 and V6. That's why it will not produce a negative wave in the QRS complex. It will not produce a negative wave. So that's why Q wave will be absent in case of left bundle branch block. Anyway, I'll be telling more on this when I will be teaching the bundle branch blocks. Okay, so just remember as of now that if the Q waves are absent in V5 and V6, that suggests it is a left bundle branch block. Now, when do you call it is a pathological Q wave? If Q waves are more than 2 millimeter deep, then it is a pathological Q. Of course, except lead 3 and AVR. Lead 3 and AVR may have a deeper Q, but apart from that, in any other lead, if you are getting a more than 2 mm deep Q wave, that is abnormal. Similarly, more than 40 mm wide, if it is more than 40 mm wide, then it is abnormal. If you are getting, if it is more than 25% of the R wave, again it is abnormal. Similarly, if you are getting it is in the V1 to V3, it is abnormal. Okay. So these are the pathological Q wave definitions. If it is more than 2 mm, if it is more than 40 mm wide, if it is more than 25% of the R wave, or if you are getting it in the V1 to V3. Now, if you are getting a pathological Q wave, what will be your differential? The most important most important diagnosis if you are getting a pathological Q wave has to be myocardial infarction, acute, subacute, or chronic. Okay, so most important is myocardial infarction, subacute, or old MI, that is chronic CAD. Okay, so this is the most important differential diagnosis. But apart from that, in what other condition you may get a pathological Q wave? Remember, whenever there is a septal hypertrophy, because I told in the lead 2 and all, the septal depolarization is represented as Q wave. So whenever there is a septal hypertrophy, you will get a Q wave. And you must be knowing that septal hypertrophy is classically seen in hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy or any other infiltrative disorder causing a septal hypertrophy. Okay, so the important point is septal hypertrophy. Whenever there is a septal hypertrophy, you will get a pathological QF. Okay, we will get a pathological QF. So these two are most important ones. Sometimes it may be a normal variant, sometimes it can be seen in dextrocardia and all. So dextrocardia or sometimes wrong lead placement, wrong lead placement. Okay, so these are some of the other causes for QA, but the most important ones for exam are MI and hypertrophic cardiomyopathy, myocardial infarction and hypertrophic cardiomyopathy or septal hypertrophy. Okay, I will see some of the ECGs. Okay. Now, as you can see here, this you can see a very deep QA here, and you can see there is ST elevation also in lead 3 and also in lead 2 and also in lead AVF. So this is actually inferior MI. This is inferior wall MI. I told in MIs you will get a pathological QF, so you can see the pathological QFs in inferior MI. More on these MIs we'll be studying later, so then you can understand more on this. Okay. Now, after finishing PVF and QF, let us study about the R wave. Now, R wave, you have to remember, we have to study about three abnormalities. One is dominant R1, R in V1, dominant R in AVR, and poor R wave progression. Okay,